Hi, thanks very much for this opportunity to tell you about my project. I'm Michael, I'm one of the medical and research students with Monash University. So first, I'd like to introduce you to Adam. He is a 24-year-old man who presented one day after being the groom at his best friend's wedding. As you can see, he presented with a fractured mandible, multiple lip lacerations, and a blowout fracture. The worst part about this is that the perpetrator who assaulted him was actually the groom. There'd been a lot of drinking the day of the wedding, and obviously things got a little bit out of hand. So while this is a significant injury, it's actually just a small subset of the full impact of alcohol-related harm. So globally, every year, there are 2.3 million deaths from alcohol attributable causes. That's from the latest Global Burden of Disease study. It's also ranked as the 9th leading cause for disability from disability adjusted life years. And this has been slowly rising over the past 25 years. Additionally, it's the 3rd behavioural risk factor behind smoking and childhood undernutrition, as measured by this study. And most of the burden of disease is related to liver disease, mental health, and injuries. As you see in Australia, it's ranked as the 7th highest leading risk, which is in line with other high-income countries, where it's ranked as the 6th leading cause. So in Australia, scenes like this on public festivals and events, as well as major sporting events, are not uncommon. And as we saw in Adam's case, it doesn't take much for them to spiral out of control. Additionally, there's most recent research of the economic impact of alcohol estimates its cost at nearly $14.5 billion every year, which is likely to be underestimated when you consider the indirect costs related to other people and the effect of alcohol. From this, 12% of this $14.5 billion is associated with healthcare costs. A study conducted here at Monash Health across 9 EDs, 24 hours a day for 7 days, showed that nearly 10% of ED presentations are alcohol related, showing it's a significant burden. And a snapshot study done on Australia Day across nearly 100 EDs across Australia and New Zealand actually put this rate at even higher at 15%. The ED has also been considered the ideal setting for what's termed the teachable moment. So as we can see in this diagram, which was originally designed for smoking cessation, the teachable moment results in significant behaviour change as a result of a cueing event. So for instance, ED presentation or hospital admission. So interestingly, in Adam's case, he'd actually presented 12 months earlier, also alcohol related, with a simple laceration of the face. And as we can see from this, as we'll go through in this diagram, this could have been an opportunity to implement the teachable moment and perhaps change his future outcomes. So in Adam's case, he may have had an emotional reaction to the injury, particularly if it's on the face. There may be cosmetic associations. Then there can be the connection of the alcohol to his injury and the recognition that it may have contributed, and the increased perceived risk of alcohol in that context. This then leads to a change in the social role, and then provided the appropriate acquisition of skills and motivations, can lead to significant behaviour change. However, what we see in the evidence around this is that not all responses are equal, and we don't know specifically what influences the teachable moment and what effect intoxication has. So currently there's established evidence for limiting the availability and the affordability of alcohol on reducing its related harms. And there's also been significant research into the idea of screening and brief intervention, particularly using the audit tool, which is the alcohol use disorders identification test. As you may have seen in the emergency department, there's been the implementation of this strategy with the help of Hello Sunday Morning, which has been now utilised effectively in ED. The audit score is particularly effective. It's a short tool which can be used in a computerised form as well, such as in the app. A score of less than 20 is appropriate for brief intervention, and anything over 20 is defined as dependent. In terms of the most recent evidence for the effectiveness of brief interventions, however, most recent meta-analysis showed small and varied effect size, with a standard mean difference of 0.9 for both quantity of alcohol, how much you drink per day or per week, and then intensity, how much you drink per drinking occasion. What's interesting, however, is that controls do have some reductions in drinking differences. So now we'll move on to the study. In terms of the literature gaps that we're hoping to address, we're hoping to hopefully define the teachable moment in alcohol-related cases, and specifically when is it most applicable? Is it on presentation, on further follow-up, or in another time frame as yet undefined? We're also hoping to look at the factors that influence change. Is it the severity of the alcohol presentation, how recent it was, and things like that, and who is most likely to benefit. So particular patient factors, the age in particular we'll be looking at. In terms of our aim, we're hoping to define and investigate the concept of the teachable moment and then develop a model for clinical practice, which will hopefully reduce alcohol-related harm. So the methodology, it's a two-stage qualitative phenomenological study. The first stage involving semi-structured face-to-face interviews. These interviews are designed to get complex responses from the patients that can then be analysed for common themes, and then this will be used to develop a new clinical model. In terms of the inclusion criteria, any patients who are over the age of 18 and have an alcohol-related presentation, as either defined by a triage system keywords such as alcohol, intoxication, drunk, or other ones, or if the clinician has significant belief that alcohol is related. In terms of exclusion criteria, moderately to severely intoxicated patients will be temporarily excluded. However, we can revisit them later on to determine whether or not they are applicable once the effects of alcohol have worn off. Additionally, dependent patients will be excluded, any patients with confounding drug use, and as you can see, they're critically ill patients and patients with significant intellectual disability. Yeah, okay. So in terms of the data collection, patients will be recruited at high times, which is Friday, Saturday, and possibly Sunday nights. And they'll be recruited until the saturation of results, which is effectively no new themes are being revealed in the collected data, which we're anticipating to be somewhere between 12 and 20 patients. The interviews will collect basic demographic information, such as their name, age, sorry, not the name, their age, the gender, socioeconomic status, and education level, things like that. We'll also collect information about the alcohol presentation, how much were they drinking, in what context, and over what time period, as well as their previous history with alcohol. Additionally, we'll take an audit score on all patients, and then we'll ask questions that are aiming to get their perceptions and their emotions around the presentations. And then additionally, look into their alcohol attribution, how much they think alcohol caused their presentation, and whether this is likely to influence any behaviour change. All of these interviews will be recorded and transcribed, and then analysed using NVivo 11 software, which will analyse for common themes, which can then be used in combination with the existing data to create a clinical model. So in terms of expected outcomes, this is a unique study. It's the first patient-driven qualitative ED-based study looking at the teachable moment in alcohol. There has been some investigation into patient factors that may influence alcohol-related behaviour change. Key ones include alcohol attribution, how much they attribute alcohol as causing their presentation, their level of dependence to alcohol, as well as their willingness to change or readiness to change. However, there's mixed results with these, and the results appear to be of limited clinical significance. So we're hoping to further inform future research by getting identifying important patient factors which will influence change, as well as understanding how these patient factors influence the teachable moment and also their reaction to brief interventions, which is hopefully going to lead to better outcomes for patients such as Adam. We'll use this information to modify the current data that we have, including the app, which we mentioned before. So thank you very much. So these are the references that we used throughout. And now I'd like to open up to the floor for any questions.